Thank you, Scott. Thank you, folks, for having me. As we go into the last panel in Washington, I have to call on one of my favorite quotes from the great Senator Morris Udall of Arizona, who said, "Everything has been said, but not everyone has said it." So I will hopefully spend a little bit of time talking about a patient-centered, intuitive, bipartisan, and multi-stakeholder supported solution that perhaps we could go beyond the rehashing of this issue from 1888 and actually start to make progress regarding these types of things. A little bit about myself. I am not an oncologist. I'm a practicing general internal medicine physician. My interest, though, is in medical blockbusters and innovation. I was introduced to the United States Congress as the shallowest guy in academic medicine, which, unlike the oncologists in the room, would take that as an insult. I took that as the ultimate compliment. I have worked on a number of things like blockbuster drugs and laparoscopic surgery, electronic medical records, and lots of medical laws. And I actually coined the term the Katie Couric effect, and was pleased to see that Katie's Today Show colonoscopy probably did more for the public health of Americans than $1 billion of basic science funding in this disease. And I think it's one of these things that brings across the spectrum of where we need to focus our attention and our resources, particularly in fora like this, where we do have the wonderful opportunity to bring all the stakeholders together and have a very reasonable dialogue. For the sake of my 3 undergraduate interns who are sitting back in Ann Arbor following today's presentation, I would hope that at least 2 of you who know what Twitter is to follow us at @U_value-based insurance design, where everything I will say today and everything you ever wanted to know about VBID can be found for your free access anytime. So I'm trying, unlike the somewhat heavy earlier presentations in the day, to leave you maybe with 3 or 4 pithy sound bites that may hopefully capture the essence of the day and allow us to move forward. And as Morris Udall said, I'm not going to repeat these types of things. We know we've done well. We have a long way to go. And I think no matter where I go, whether it be the U.S. Congress, state capitals, boardrooms of large corporations, and union halls across the country, I wish people were talking about the quality gaps, and I wish people were talking about the need to get healthier. But I will tell you, with the exception of portions of these meetings, what everyone really costs about is how much we're spending. And I'm very impressed by the IOM organizers that we didn't see at least 5 versions of the slide showing how much the United States spends relative to other countries, because I think we're all very much aware of that. And I think that the issue at hand is very clear in all of medicine, but specifically to cancer care and oncology. There are things that we should be doing more of. There are things that we should be buying more of, and we should be spending more in oncology across the entire spectrum of care, whether it be prevention and screening, whether it be visits and early stage interventions, whether it be very intense chemotherapeutic and surgical interventions, or end-of-life care. And I think that the pithiest soundbite of the day, and I wish I had my foam finger to tell you, we must collectively change the discussion on healthcare costs, whether it be cancer or generally, from how much to how well. Because we have enough money in the system, right? It's just, we need to think about that there are some things that we are not buying enough of, and I'll leave that up to you. And there are some things that we are buying way too much of, and I'm actually floored to come up at 3 o'clock to not have anyone talk about the exorbitant amount of money we waste in America on healthcare, whether it be oncology or elsewhere. And that many people would estimate that, listening to the previous panel, that we may have to take away dialysis from other people to pay for high-value cancer drugs. There are estimates of tens, if not $100 billion a year on waste of things that either don't help people or actually harm people. That if you don't start taking attention to that as oncologists, that other people like bureaucrats are going to start dealing with that. And I'm hopeful sometime during the discussion we'll have at least a moment to talk about the cover that the Choosing Wisely program is giving us across 50 to 60 specialties to talk about low-value care. So I have struggled, and I've known Scott Ramsey for a very long time, to try to get involved in this issue of how much a drug should cost and how much an insurer should pay for it. And I abandoned that strategy about a decade ago. And I think for my remarks, I want to focus up on follow up on Shelley's comments, is that I want to talk about a patient-centered or consumer-directed approach, and that when I talk about cost now, I'm going to talk about the cost to the individual who has some form of health insurance, public or private, right, through the exchange or through a large group or self-insured. Once the decision is made to cover a certain service, this is the amount of funds out of the patient's pocket. And although an earlier comment was made that maybe the consumer should care about the overall cost, the evidence is overwhelming in cancer and elsewhere that they don't. And for now, I think that if we're going to start these baby steps to get from how much to how well, we should start aligning at least the consumer incentive around what they're paying to what they're buying. And I think completely concurs with the majority of the statements made. So there are experts here, and Mike was sitting here, I was nervous, but there are hopefully still folks here in the room from the insurance industry who know a lot conceptually about the idea of consumer cost sharing. But I want to remind you that if you go back to Insurance 101 and look at the motivation for consumer cost sharing in healthcare, this is to get individuals to think twice or thrice about services they don't need, right? So my primary care patient with 2 sisters and a mother with breast cancer should not think twice or thrice about her mammogram. My patient with similar family history of colon cancer should not think twice or thrice about colonoscopy or the follow-up care as recommended by the gastroenterologist or the medical oncologist. That said, just about every American, including most of you, sit in a health plan now that has a cost-sharing situation that you pay the same out-of-pocket for every doctor visit, say within your network, for a cardiologist after a heart attack, or for a dermatologist for the acne I could barely see. Same cost share for every doctor within the network. Same cost share for every diagnostic test. And same cost share for every drug within the tier of the formulary. $4 for drugs that I beg my patients to take on the generic tier, $4 for drugs I would not give my dog. 20% coinsurance for drugs that cure cancer 90% of the time, 20% for specialty drugs that never cure a case at all, right? This to me, not an insurance executive, not an economist, seems to make no sense. As I've traveled 49 states, if anyone here from North Dakota? 49 states, I have not had anyone push back to tell me that the one-size-fits-all benefit design is a really good idea, and nor it's something they would create from scratch if they were starting today. But not only do we have one-size-fits-all benefit design, we also, we've seen 9 or 6 times on the slides today, the cost sharing for Americans for all services. So this is visits, this is diagnostic tests, this is all tiers, maybe the exception of generic drugs. We are paying more for everything. As we make people pay more for everything, they buy less of the things they should think twice or thrice about buying. That is why cost sharing is in place. However, they stop buying the things that we beg our patients to do, right? And in some situations, when they stop buying those things that we beg them to do, not only are they harmed, it actually costs all of us more. So the motivation for value-based insurance design comes from the country's great philosopher, my mother, who said, I can't believe you had to spend $1 million to show that if you make people pay more for something, they buy less of it. And I will say to you that I knew Yusuf was coming before me, and I didn't know Mike was showing my colleague Stacy Decina's study. I've kind of motivated Stacy to get into the area of price elasticity to drugs. She moved from other classes now, publishing very nice papers in oncology, but she, like all of you, I think, know my mother is always right. And your mother is always right. And now there is a robust set of studies. When I first met Michael, there were probably 2. Now there are 35 to show that my mother was right. This is good stuff and bad stuff. This is rich people and poor people, right? This is people of all races, that when you make them pay more for something, they buy less of it. And if there remains to be someone in this room who wants to take me on about skin in the game, and that if you actually make people pay more for something, they'll buy more of it, show me a study that that holds to be true in any aspect of the economy, not just in healthcare, right? Show me anywhere that if you make people pay more for something, they'll buy more of it, right? So I don't know how the country kind of got behind this idea of skin in the game. This is different from consumerism. This is different from education. This is different, Shelley, as you said, about shared decision making. This is the idea of just hiding some of these principles to the fact that we're going to make you pay more through cost-sharing deductibles for all parts of your care. Mike Chernow and I, now at Harvard Medical School, thought this is kind of a bad idea. That patients in my practice in Southeast Michigan with really good insurance, as we heard before, were not doing the things that I begged them to do. And one of the many reasons, I want to emphasize, one of the many, many, many reasons why people don't do what they're supposed to do regarding their health is due to cost-related problems. So imagine when I went to my mother and said I need another $500,000 to show that poor people were impacted by high copays more than rich people. And of course, we got the funding to show that poor people, in fact, were more sensitive to high prices than rich people. And we are happy to say that the value-based insurance design discussion actually ties very nicely in to an area of interest that I've had for many years, which is reducing socioeconomic and other healthcare disparities. And you can understand that as we struggle with the fact, as Shelley was saying, one size fits all is easy to talk about, and personalized or customized or other types of interventions are hard. But there are lots of signals out there that might tell us that there's a fairly straightforward and easy way for us to move forward to start chipping away at the problem of the poor value we're getting for healthcare expenditures, particularly oncology. So here is the moment of the inception. And remember the Leonardo DiCaprio movie a few years ago called Inception? I'm going to put my idea in your head. When you leave, it is your idea. Okay? I want it to be your idea. And this is the critical aspect, I think, if I had a chance to tie the whole day together or my 21 years of career together, is the term clinical nuance. This is particularly notable for the people with PhDs and not RN, PA, MD after their name. Medical services differ in the clinical benefit provided. Right? Even though the insurance coverage you have incents you equally for every drug, every diagnostic test, and every doctor visit, you know that there are differences. And I tell this great anecdote, I'm watching the clock, Scott. I was talking to a bunch of AARP members in Boca Raton, which if you've been to Boca Raton, that after Mahjong, going to your doctor is the #1 hobby there. And if you know anyone in Boca Raton, typically they have lots of doctors, and if you're on one prescription, the evidence we all know shows if you're on one prescription, you're on 10. And I was talking about this idea of different drugs have different value, different doctors have different value, and this woman, she was 4'10", came up and stood on a chair after my lecture and said, you know, Dr. Fendrick, I have 10 doctors, and I have a Christmas party for them every year. And she said, you know, I like them all the same. And then she bent over and whispered in my ear, she said, but I know some of them impact my health more than others. And it was that day that I knew that we could take this VBID concept and the idea of clinical nuance forward, that no advocate or policymaker or lobbyist in Washington tell me that we could not explain this idea to patients around the country, regardless of their level of literacy, regardless of their level of education, that people understand that visits may vary in terms of the quality they get to them as an individual. It may not be the same as what the doctor thinks, but people understand that some are better than others, even though almost all private and public health plans incent you equally to do the same. The challenge to oncology, which will come up, I'm sure, many, many times during the Q&A, is that this second aspect of clinical nuance, which is even if you pick a service to be high or low value, that service depends on who gets it, who provides it, and where. And a lot of these issues have been raised today already, right? So my area of interest, luckily I don't treat cancer patients, you all do. I try to prevent cancer. Colorectal cancer screening, a great interest of mine for 2 decades. I have said publicly many, many times that if you are a first-degree relative of a colon cancer sufferer, Aetna, United, the Blues, Medicare should pay people to get screened. And we've published on this. I think the evidence is quite strong to suggest that the risk is high and the cost of treatment high. You drive the cost of colorectal cancer screening down, it is a dominant strategy. I've said for many, many years, if you're 50 years old, colonoscopy or other colorectal cancer screening should be free. I say with great humility, that is now the law of the land. I've been saying it so long, it wasn't the law of the land, now it must be free. If you are 28 years old, have no family history, and are motivated to get screened by Katie Couric's really tragic story, right, which our own study showed people did, at that age, you should pay 100% of the cost of that test and be fined $500 for taking your mother's appointment, right? Because clinical nuance tells you that it's not just the service, it's who, when, and where. And the when and where, the where has certainly been discussed earlier in the day, and that's a very big issue in oncology, whether it's inpatient, outside, whatever else. I'm not going to belabor those points. So we operationalize this concept of clinical nuance into something called value-based insurance design. There are some few people around who still call it value-based benefit design. It's the same thing, but Mike Chernow and I like to say VBID as opposed to VBBD. So that's the only difference. Here's the interesting part with lots of academics in the room, but also loving the fact that there are real doctors, community-based providers, non-physicians in the room, is that in the academic world, we are judged by when we publish research papers. I will tell you, you've heard the term publish or perish, right? I published and I still perished, right? It wasn't, I was hoping, Peter, that you would have timed it perfectly. 10 years ago, in a few days, Scott Hensley of the Wall Street Journal wrote about value-based insurance design in the Wall Street Journal of Medicine, not the New England Journal of Medicine. And that was the day our lives changed, because that was when I realized that change agents in healthcare were not us, academic physicians. The change agents were the people in this room representing multiple stakeholders, employers, patient advocates, providers, health systems. And it was this day that people just said, wait, maybe it's a good idea for individuals actually to pay less for statins than they do for that heartburn medicine that's now in Michael's bowl, right? Maybe it's a good idea to pay less for insulin in a certain tier of the formulary than to pay for a drug that'll make my toenail fungus go away or my hair grow back, right? And people started listening and say, yeah, that's not a bad idea. And we could actually move this idea along. And now we've been implemented by hundreds, if not, we're getting close to 1,000 public and private payers who are starting to understand that one size fits all, not a good idea. Some do it with just a few classes of drugs. Some pick a few high-value diagnostic tests like hemoglobin A1C. Some pick diabetic eye exams. Some pick PT after hip replacement. But others are starting to understand that certain services are high value and for which I should not create a substantial financial burden for my individual clients and patients to get it. You can imagine now I'm trying to build up that there has been interest for us to have the guts to start talking about VBID in specialty pharmaceuticals and specifically in cancer care. But we wanted to take our time, and because Mike Chernow and I are the tortoise in this race as opposed to healthcare transformers in Washington or always the hares who have this great idea of save lives, save value. They come in for 2 years, they blow up, burn out, and go away, right? We did not ever make a claim of saving dollars. We wanted to just start people to understand that we could get more health for the money that we're spending. And the early implementers of value-based insurance design primarily did carrot VBID programs. They picked high-value services, most of the time prescription drugs, generic and brands in classes, and made them more accessible than other drugs in those classes. And Lee and colleagues published about a year ago the first really good systematic review of carrot VBID programs in health affairs. And lo and behold, imagine when I told my mother I'm really excited about a review that's going to show what happens with the drug adherence when you lower costs. They take them more often. They don't take them much more often, between 3 and 9% if you lower costs in that situation. Very importantly, the patients were always happy. And secondarily, for the ultimate payer, there was no increase because we targeted those drug classes for which offsets occurred fairly quickly. In the last month, the Aetna group, led by Nitish Chowdhury and Will Schrank, now at CVS Caremark, published a paper of the best VBID implementation, a randomized trial of full drug coverage for heart disease care. And what they found in the non-white patients, that not only did we see these adherence increases, which we expected, they actually saw significant cost savings in that group, suggesting that targeted value-based insurance design programs not only improve outcomes, save money, and also reduce disparities. So very excited about that. Quickly on this, what makes a good VBID program now? Again, not very much in the oncology realm, the more generous, the more targeted, and the more tied to wellness programs. Just going to spend a few minutes quickly on the fact that we took this idea out of the ivory tower, brought it here largely through the business community to Washington. We have strong multi-stakeholder and very, very rare bipartisan political support on this, which it may be important to a small cadre of people in the room who may not understand how hard it is to actually make real legislative and policy changes around healthcare in 2014. You say we can't do it? Value-based insurance design was included in the Affordable Care Act. It's probably one of the most popular aspects of the ACA that's free primary preventive services that are called named A or B by the U.S. Preventive Services Task Force, HRSA, and ACIP at the CDC. Fascinating, if you ask people about whether they like free primary preventive services, 98% say they like it. If you tell them that it's a part of the Affordable Care Act, it drops to 50. So that just to tell you that what's going on here in the U.S. I'll tell you, though, that when it comes to cancer, the implementation of these recommendations from the task force are challenging, right? Colonoscopy may be hard enough. I think most plans could pick age. Finding your family history due to other GINA and other requirements are hard. And even the most recent task force recommendation of A or B, the very somewhat controversial aspect of CT screening for lung cancer, the recommendation says you had to be a smoker for 30 years and not quit for 15. There is not a health plan I know in the country that can accurately tell me who their smokers are, let alone how long they smoked and whether they actually quit, which is why my personal reservations about covering this thing is just going to be really, really, really hard. There are also some recommendations from the task force regarding treatment. And I'm really hopeful that the health plans will start to adopt the treatment recommendations from the task force and make these things like aspirin for secondary prevention free, which most insurers are doing, as well as a more recent recommendation for chemo prevention for high-risk breast cancer. Imagine how hard that would be to implement, because we just can't find that in the simple claim system. I'm going to skip over this. I'm going to get to the important aspect here. So applying VBID to high-cost cancer care. Again, I thank the organizers for timing today's conference at the day of our release of our white paper. It is here in my hand. There are a few copies out front, but it's all available, again, for free if you Google VBID. We passed Vehicular Born Incendiary Device in 1999, so you will find it on our website. And what I think we should do, Shelley, to you, the solution could be a number of things. You could pick from these. Someone's taking a picture. You should tweet it. Tweet the picture. Make me happy. Impose no more than modest cost sharing on high-value services. I think someone mentioned a couple of that earlier. This lacks the whole nuance thing that I've been basing my career on. I think it's a good idea that people should not go bankrupt, particularly on evidence-based services. I think the second bullet here is what I'd love to hear some comments on, that we could reduce cost sharing in specific to patient or disease-specific characteristics. And I think that is particularly useful as we see the growth of companion diagnostics. I think this idea of making sure people have a lower cost share if they test positive for a marker that actually shows a higher likelihood of a medication success is a no-brainer and something that both providers and plans can implement. We also have an issue that comes up in specialty. I'm not so sure how much it comes up in oncology, where there's this pressure to try a less effective, maybe more toxic, we heard about this morning, drug first, where we know we have a better, more expensive drug second, and there always seems to be this or that. I came up with a concept called reward the good soldier, which is called in pharmaceutical benefit terms step edit with copay relief, that if you try the drug at lower cost and it doesn't work, and the oncologist says it doesn't work, or the patient says the side effects are too bad, I believe that most health plans and PBMs can implement a program to give you some type of cost share reduction because you tried. Because I don't think every person actually in every situation should have the right to the highest cost therapy first line, but I don't want to see situations that's just divided yes or no. And I think this is just maybe a start to have a conversation of a fluid dynamic between maybe in the area of rheumatoid arthritis, you should try methotrexate first. And if the methotrexate doesn't work very well or it's too toxic, you should get a break if you need a biologic. And someone could give me an oncology example that I could use next time around to fill in there. And of course, again, tied to Michael Oj's statement and whatever else, there's been lots of action around high-performing providers in the area of oncology care. And I think that we could take leverage on what we've done on cardiovascular care, giving lower cost sharing and incentives for individuals to go to high-performing providers and centers of excellence. It's not going to be hard, right? We have a number of implementation keys in the white paper that we mentioned. It is administrative complexity, it's communicate effectively, and the last point I'm going to make is how to integrate this with provider initiatives. I have been at a number of IOM meetings talking about the potential value for electronic medical records, and I think most of us have been somewhat disappointed in what we've been able to return on our $50 billion plus investment in EMRs, because again, I think the incentives have often been in the wrong place. I think if we had a number of the people who make the large EMRs in this room, or the oncology community can turn to the EMR manufacturer and say, make it easier for me to identify things, and ultimately tie what's happening in the EMR to tell the patient what is evidence-based, and maybe more importantly to what Shelley said and Yusuf said earlier, what it will cost. And you don't tell them the bad news early on about how much it'll cost. You tell them the first time, oh, by the way, because you are 50 years old, you get your colonoscopy for free. Because you're a high risk for breast cancer, you get your chemo prevention for free. And that is what we've been able to elevate in a couple pilots around the country regarding this. The last thing I will say is I'm going to get ready for my very sophisticated academic conceptual model here. Most of the discussion today, and it will continue in areas of cancer or otherwise, about reforming healthcare tend to be provider-facing, or what I call supply-side initiatives. ACOs, pay for performance, medical homes, health IT, MOUSE, all those things. I call those, for the sake of my time on Capitol Hill, I call those peanut butter, right? I am, as a primary care doctor, incented a great deal to get my diabetic patients to the eye doctor every year. The work in VIBA that we're doing is consumer-facing or demand-focused. I call that jelly, right? I tell CEOs of Fortune 50 companies, you are paying me to get diabetics to get their eyes examined every year, and you're enrolling them in health plans for which they have to pay 100% of the cost of that test until they run through a $12,000 family deductible in a high deductible health plan. And these folks know a little bit about management, that they're paying me to do something and make it harder for the customer to actually do it. In the self-insured world, they know the beauty of the first time, close your eyes, the first time where peanut butter and jelly came together, where the sum is greater than the individual parts. And as you consider all of these things to get individual doctors, groups, health systems, health plans to do something, please, 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 please make sure that the consumer's incentive are aligned with those things, as opposed to the current situation where the peanut butter and jelly are not coming together, but in fact they are getting further and further away. So it's the patients first, health matters more than costs. Very importantly, last pithy soundbite, cost containment efforts should not produce preventable reductions in quality of care. The one-size-fits-all costing that we're seeing to all patients for all things is harming people in a systematic way. Clinical nuance and value-based insurance design, implemented even in a baby step way, I think should be part of the solution to enhancing efficiency in cancer care. So thank you very much. Shelley, thank you for the few extra minutes, and I will give you a chance for the next speaker to come up.
One more minute, Mark, and you're going to have to pay your mother $500. Okay. Our next speaker is Tom Feely, who's going to talk about bundling of payments. Tom?
Well, thank you, Scott.